Dear colleagues, this is phacoemulsification of a mature non-intumescent cataract. Let us observe the surgical steps. This is the main incision at the posterior aspect of the limbus. Now, this is a side port on the left side of the main incision. This is another side port on the right side of the main incision. Now, a big air bubble is injected into the anterior chamber. Beneath this air bubble, trypan blue 0.06% dye is sprayed over the anterior capsule of this mature cataract. When the dye is applied underneath an air bubble, the dye is not diluted by aqueous and the staining is very quick. The dye is washed out. Viscoelastic substance 2% hydroxypropyl methyl cellulose is injected into the anterior chamber. And now is the time to do capsulorhexis. A 26 gauge bent needle cystitome is introduced. The anticapsule is incised. Note that there is no leakage of oily fluid, indicating that it is not intumescent. This is a non-intumescent cataract. Since the pupil is mid-dilated, the rhexis goes all along very close to the margin of the pupil to get an adequate sized rhexis. The rhexis size in this case is about 5.5 mm or 5.75 mm. Little bit of hydrodissection is done. When the cataract is white, inject little bit of fluid. Very gently try to rotate the nucleus and the nucleus rotates. SPMC is injected again, and now is the time to introduce the tip of the phaco handpiece. The machine being used is Oatly Catarix 3. The tip is introduced, bevel down, the cortical matter which is floating is removed. Now visibility improves. With the help of the left hand, the handpiece is rotated and the bevel is turned upward. And now see the direct chop. The tip is buried into the substance of the nucleus very firmly, and now go underneath the rhexis margin and slice the nucleus. Hold the nucleus at another place and chop it here. This free nuclear fragment is emulsified. This is another free nuclear fragment. This is the other heminucleus. It is also held firmly using high vacuum, and it is chopped and emulsified. Vacuum used in this case is 450. Flow rate is 45 ml per minute. Ultrasonic energy used is 60%. And now, during emulsification of the last bits of the nucleus, the chopper is removed and emulsification is done single-handedly. Just be at the center. And now you can see a very thin sheet of epinucleus. and this should not be attempted to remove at on go. Inject some viscoelastic substance beneath this epinuclear piece. Go behind the epinucleus and remove the thin sheet of epinucleus. And now viscoelastic substance is injected again. A 23G Simcoe cannula is being used to remove the cortex. See how you should hold the cortex. Move the tip of the Simcoe side to side while you create vacuum by suction. And in this way you can hold a large chunk of cortex and remove it. That's it. The cortex is removed 360 degree. There are some cells sticking to the posterior capsule just in front of the main incision. With patience, yes, patience is required for meticulous surgery. We must develop patience. We, the surgeons, must develop patience. Now I am using bimanual for removal of those cells. Just in front of the main incision. After being in IA1 mode for a few seconds, I went to IA2 mode, that is capsule polish mode, and polished the capsule. And now under irrigation, a foldable intraocular lens is being implanted in the capsular bag. That's it. And now the lens is in the capsular bag and there is no viscoelastic substance. Little bit of moxifloxacin has been injected and now the side ports are hydrated so that these stab wounds become watertight. After closing the side ports by hydrating the stroma on either side of the stab wounds, a final lavage of the anterior chamber is done with balanced salt solution. And I do this with a 23G Simcoe cannula. The viscoelastic substance that sticks to the corneal endothelium comes out during this final lavage of the anterior chamber. And then the antechamber is formed and the case is concluded. Thank you very much. Hope this video will help you in developing your surgical skills.